Good morning, everyone. Welcome to the Alzheimer's International Society webinar, a critical review of the recently FDA-approved anti-amyloid drugs for Alzheimer's disease. Alzheimer's International Society is a nonprofit organization with the goal to facilitate and accelerate the research to find prevention and treatment therapeutics for Alzheimer's disease and to provide services and support to our stakeholders around the world. It is our pleasure to introduce our moderator for today's webinar, Dr. Zung Tran.
Thank you very much, everyone. I know that the last I looked at the registration list, there are about 450 attendees. So this is really exciting for us to be able to speak to such a large audience. Today, we would like to welcome our three panelists, and I will also be speaking. But very briefly, we will have Professor Rudolph Castellani, Professor Alberto Espay, and Professor Karl Herrup. And the way in which our format is going to be that each one of our panelists, including myself, so there will be 4 presentations. We would like to ask each panelist to keep their presentation to about 10 minutes, so that there will be room for there will be time for questions that have been posed by the registration people, the attendees, prior to the start of the webinar. I've compiled the questions, and I will use that to start off the discussion after each panelist have made their specific presentation. Also, if the panelists would have slides to show as part of their presentation, we'll be able to allow you to share your screen. So this is the list of the panelists and myself, moderator. So to start off, I would like to perhaps just go into that particular order, have each professor and panelist spend a minute or two introducing themselves. Okay, Professor Espay.
Hello, everyone. Thank you very much for this kind invitation. I'm Alberto Espay. I'm a neurologist at the University of Cincinnati. I am a movement disorder neurologist, so I came onto the field of Alzheimer's through the back door of Parkinson's, recognizing that there are many, many similarities in the way we think about our diseases. And I'm very happy to join my colleagues here in this panel. I'm looking forward to the discussion.
Next, Professor Castellani.
Yes, I'm Rudy Castellani. I'm a neuropathologist. I've been at various institutions over the years. Most recently, I'm with Northwestern, Feinberg School of Medicine, and our Alzheimer's Disease Research Center. I've had an interest in neurodegenerative diseases since the 1990s, and I look forward to the discussion.
Professor Herrup.
Good morning. I am Karl Herrup. I am not a professor of neurology, as the slide says. I'm a professor of neurobiology at the University of Pittsburgh School of Medicine. I'm a basic scientist and been interested in neurodegenerative disease for at least 30 years now, actually probably more. And I too am very much looking forward to the discussion we're going to have today.
Thank you. And finally, myself. I'm Zung Tran. My training is in biostatistics and bioinformatics. And I am a retired professor from the University of Colorado School of Public Health and the School of Medicine. In my career, I did a lot of clinical trials. I have expertise in one of the pioneering people who did a lot of meta-analysis, developed a lot of meta-analysis methodology. Today, I represent the Alzheimer's International Society as a senior scientific advisor. So with those introductions, perhaps I would ask Professor Espay to provide the first 10-minute presentation.
Will do, and my screen needs to be enabled for sharing. If somebody could do that for me. There we are. Thank you. Great. Sure. And I ask, could you see this slide? Okay. Excellent. Very good. Well, I'm happy to have been given the chance to go first because I will provide the bird's eye view, and then I will end in these 10 minutes on what I think is the novel way of looking at the data that hasn't previously. So the question that I want to ask is, what would make lecanemab exceptional? And I'm going to talk about the two ends of the protein homeostasis to make sense of it. So these are my disclosures. The one that makes some relevance here for what I'm discussing is the last one that I have accompanied with colleagues that are developing a synthetic non-aggregating analog for the protein replacement strategy to be enacted in the future. So the idea that Alzheimer's is biologically defined by an A+ is having a lot of difficulties because this large study from the Mayo Clinic study of aging showed that the curves between the A+ and the dementia diverge. In fact, they diverge for most of the 15 to 60 years beginning in the 60s. And what's interesting about this is that it really is quite fascinating to know that if these curves were to join as the amyloid hypothesis predicts, that would be the kind of curves that we would see. Instead, of course, by the age of 85, you can see that there is a 5-fold lower prevalence of dementia than predicted by amyloid positivity if it were toxic as we've conceived it. So, of course, you all know about this model. Everything goes up, but in fact, in degeneration, there is a loss. And the first thing that happens is a loss of A-beta 42. In fact, it's been demonstrated that happens a couple of decades before the first symptoms of what we call MCI and eventually dementia. What goes up is the insoluble fraction, but not in absolute terms, rather in relative terms, as A-beta 42 becomes transformed into its insoluble counterpart, and that becomes quantifiable by amyloid PET. What we've previously shown is that the levels of A-beta 42 are quite important, in that if you have levels above 800 picograms per ml, you would mostly be cognitively normal, regardless of any level of amyloidosis. Here you see the SUVR, the metric by PET, one of them that allows us to quantify the insoluble fraction. Even at the highest tertile, that relationship continues to be, whereby higher levels of A-beta 42, in fact, predict or are associated, in this case, a cross-sectional study with normal cognition. In a longitudinal study, this is actually much more powerful. This asks the question of whether high baseline levels of A-beta 42, this is shown in the y-axis, predict the conversion to dementia or the preservation of normal cognition. And in fact, the higher the levels at baseline, the lower the probability of progression to cognitive impairment. And this relationship is really across all amyloid burden levels. And so there is a threshold in gene carriers lower than in sporadic, rather than 800, in this case, 270 picograms per ml, levels above which most individuals will remain normal longitudinally. And in the same cohort, this is data showing that as the amyloidosis increases, the levels predicting normal cognition correspondingly go up of A beta 42. And that's quite important, meaning that a very good predictor of whether someone would convert from normal to MCI into dementia would be whether the levels of A beta 42 drop. So going into our approach of trying to determine what makes lecanemab different. Well, lecanemab is different from donepezil. If you looked at donepezil, which was the last FDA-approved drug that we ever had prior to lecanemab 20 years ago or 19 years ago precisely, you can see that this was a modest but significant change of donepezil. And what's important is that although the time duration was shorter, you can see that there is a sustained response, relatively speaking. We were told, though, that when this data came out, that we needed to not pay attention so much to the end of this trial, but rather to the fact that the curves were diverging. And as you know, that's one of the most important support statements for the idea that lecanemab is to be viewed not so much in terms of the magnitude of difference at the end of the study, but we need to remember that the curves are divergent here too, and we know they never quite diverge in the manner that we anticipated with donepezil, and they are unlikely to do so with lecanemab. But what's important is that the magnitude of difference, admitting that this is, of course, a different duration of a study, is half of that of donepezil, and no one benefits, and that's quite important. The benefit is just a change in the magnitude of decline, but not in the magnitude of improvement, of which there is nothing. So what makes then lecanemab exceptional? Well, it turns out that lecanemab actually increases the levels of A beta 42. And part of the reason to look into this is because if there was a way for lecanemab to do something meaningful, it wasn't through the reduction of amyloid, which was accomplished by 16 other anti-amyloid therapies, but presumably by the increase in A beta 42. However, it turns out that increases in A beta 42 aren't the domain exclusively of lecanemab, and many other anti-amyloid, particularly monoclonal antibodies, have done this. And this is something that I got to learn when I suggested that lecanemab was exceptional in that increase in A beta 42, and it was pointed out to me that's actually quite common. And this information was extracted mostly from supplementary materials. That column of A beta 42 is not what's listed in the articles directly. So you have to dig into that to be able to extract this data. So we've done this, and as you can see here, the protein homeostasis, of course, starts with soluble A beta 42, ends with insoluble A beta 42. So it starts with the functional fraction of the protein and ends with the non-functional fraction, which is what we can measure through an A beta PET. And you can see that there are quite a few monoclonal antibodies that actually increase A beta 42 quite dramatically. The ones that decrease it were by design. Those are the secretase inhibitors. And in those cases, as you know, cognitive function actually worsened quite dramatically. So what we've done is using this data as a sources of meta-analysis, in fact, have now data to show that the magnitude of relationship between increases in A beta 42 in terms of the cognitive endpoint are very much similar to those for the decreases in A beta PET. So an increase in the functional fraction of the protein is as relevant in terms of determining the association with the cognitive endpoints as the reduction in amyloid. And this is something that you can see here in a way that's depicted differently. This is now ADAS-Cog, and then you can see that on the left, you see the changes in A beta 42, and in the right, changes in A beta PET, according to the different studies that we had the data for. You can see that the relationship is relatively similar. Hard to make much of the slope differential here, but in conclusion, though, is that that relationship is both determined both by the changes in the insoluble as important changes in the soluble. Same thing for the CDR-SB, these other cognitive endpoints. So very much the same type of relationship. So there are two sides to any story. The functional state of proteins is where we all need a certain level of A-beta-42. And of course, the non-functional state of proteins, which is where proteins end at the end of their process of reacting against a variety of biological, toxic, or infectious exposures. And of course, it's important to recognize that there is a loss of A-beta-42. That loss happens well before any symptoms occur. And the question is whether once it transforms into amyloid through a phase transformation that's governed by the second law of thermodynamics, whether that somehow becomes toxic. That uncertainty is what we've embraced. And this is the reason why the therapeutic pipeline is largely aiming at reducing the aggregation or clearing the amyloid plaques. So in conclusion, I hope to have very briefly shown you that Alzheimer's is really not a problem of the accumulation of A-beta-42, which there is no accumulation really, but of the loss of A-beta-42. That most of us can live normal lives with high brain amyloid, but no one with dementia has high A-beta-42 levels. The high A-beta-42 is associated with normal cognition in amyloid-positive individuals and lowers the risk of conversion to dementia in individuals with gene mutations predicted to lead into dementia. And finally, that increases in A-beta-42 may in fact be the most important mechanism by which anti-A-beta monoclonal antibodies might exert their effect, though I question whether the end justifies the means, meaning the end of increasing the normal protein justifies the mean of removing amyloid. And I would argue the answer is no to that. So with that, I thank you very much for this. And this is what I wanted to put to my colleagues as well as the audience in terms of stimulating the discussion.
Thank you very much, Professor Espay. That was a very interesting, enlightening discussion. I'm sure that there will be some questions to follow. Next, I would like to ask Professor Rudolph Castellani to make his presentation.
Okay. Bear with me here. I gotta. Can you see my presentation?
We see it, but in the mode that shows the next slide for you. You want to swap the display settings so that you up in the left upper corner where it says display settings. If you click in there, you'll then see the next slide yourself, but we, the audience, see only the slide that you want to show. With the cursor, go up to the left upper corner.
Yeah, I'm trying here.
And it says display settings in the left upper.
Oh,
click on that. Yeah, click on that.
Display settings. Then how about that?
Right. Yeah.
Figured it out. Great.
Perfect.
Okay. So the discussion here is on basically on vascular toxicity, and it's based on anecdotal accounts that one of which I've seen. I have no conflicts of interest, and I'd also want to mention that this discussion are my opinions as a neuropathologist. I don't speak for any institution. I don't speak for any center. I just speak for myself as a neuropathologist. So we had the occasion to examine a case of a fatality of someone who had received 3 infusions of an anti-A-beta drug, 3 infusions over the course of a month. 2 weeks apart. It's important to point out that this particular individual was not a vasculopath. This person was actually in excellent cardiovascular health and was highly functional, actually. And we know that because the spouse consented to a complete autopsy, so we had the occasion to investigate the vasculature and the other organs and so forth. And it was a very healthy person, no atherosclerosis whatsoever. At any rate, so this person, after 3 infusions, presented with neurological signs of an ischemic stroke and was treated with tissue plasminogen activator, and developed what you're seeing here, which is multifocal acute hemorrhage. And so this is not hemorrhagic conversion of ischemic infarct. This is multifocal hemorrhage of a sort of a variety that I've scarcely seen anything like this in the many thousands of brains I examined. So this is not hemorrhagic conversion of ischemic stroke. This is multifocal hemorrhage, and frankly, it parallels the presence of amyloid angiopathy. So microscopically, we found also a fairly unique pathology, which is a histiocytic attack on vascular amyloid and a necrotizing vasculopathy, meaning what you're seeing here, some of this darker pink material is not amyloid, that's fibrin that's produced as a result of vascular destruction. There is also amyloid here. We immunostained. I'll show you a slide in a minute, but basically it's fairly clear, almost empirically evident that we're getting an immune attack, a macrophage attack, basically on insoluble amyloid. I know with some of these drugs you hear discussion of the target being soluble protofibrils, and that may well be the case. We can't detect a soluble phase, biology with a histologic section. We can see insoluble material, insoluble amyloid, and clearly there's an attack on insoluble A beta associated with destruction of the blood vessel. So that's clearly going on here. And I bring up this case. This is in the public domain. It's in the process of being submitted for peer review. I'm just showing it as another example. And I'm not speaking for the authors here. You can read the paper online. But it was a similar case. 3 infusions of an anti-amyloid drug, in this case lecanemab, that apparently resulted in multifocal hemorrhage, and the pathology that they demonstrated was identical to the pathology that I saw. So there's necrotizing vasculitis. There's some discussion about clearance of A beta and being cleared through macrophages and perivascular spaces and lymphatis and so forth. That's not the case here. This is macrophages infiltrating the blood vessel wall, phagocytosing amyloid and injuring the vascular wall, resulting in fibrin deposition and necrotizing vasculitis, and very severe. This is the extent of necrosis we're seeing is well beyond that you see in so-called amyloid angiopathy related inflammatory disease, which is a sort of a rare phenotype of cerebral amyloid angiopathy, or CAA. Back to our case, we do amyloid beta immunostains. We're seeing amyloid in the blood vessel wall that's fragmented by the macrophages. So it's basically being chewed up by the macrophages, which is, I would say that's probably part of the design of the drug. The drug is meant to stimulate an immune response to amyloid, and it's doing so. It just happens to be, in addition to plaques, which it also seems to be attacking, it's attacking the blood vessel wall and resulting in vascular injury. So what's going on here? It seems that the therapy induces necrotizing vasculitis in patients with cerebral amyloid angiopathy, resulting in either hemorrhage or imaging abnormalities or clinical symptoms or all of the above. And it's important to point out that the fibrin in the blood vessel wall here, and which make this case kind of unique, is a substrate for TPA. And so if somebody presents with an ischemic stroke or stroke-like symptoms, but actually the ischemic signs are a manifestation of the blood vessels being chewed up by the macrophages, that TPA is going to basically dissolve what's left of the blood vessel wall and result in multifocal hemorrhage, which it did in this case. So again, it's a very unique case, but very clear what's going on in this particular case. We know that the drug has an effect on cerebral amyloid angiopathy in the blood vessel wall, and it's setting up a substrate for TPA, unfortunately. And there's some discussion of course, caution is indicated in patients on anticoagulants. That's mentioned with these drugs, which is to the credit of the companies that put out these agents. But I wonder if TPA should be absolutely contraindicated in such individuals. That's just my opinion, because this case was very dramatic. So basically, these two cases suggest to me that these drugs cause a necrotizing CAA-related vasculitis. And that the question is, to what extent does that CA vasculitis underlie what we call ARIA, or amyloid-related imaging abnormalities? I would say it does so in at least some cases, maybe even most cases. I think it's important to point out that, in my opinion, there's no real good biomarker for CAA. We need a better handle on this. MRI exam will only give you a complicated CAA with siderosis and microhemorrhages. People can have plenty of cerebral amyloid angiopathy and have no MRI findings whatsoever. There's a relative tendency for people with E4 and E2 alleles to have CAA, but that's only a relative tendency. You can have plenty of CAA and have no E4 allele. So MRI ApoE genotyping is not going to exclude patients with CAA. So it's always going to be unpredictable. And I just wonder if to some extent, is this therapy actually a diagnostic test for CAA? In other words, if you infuse patients with some of these agents and their brain lights up on MRI, or if they suffer symptoms, is that because they actually have a lot of amyloid in their blood vessel wall, which is, we know that is very common in Alzheimer patients to have amyloid in their blood vessel wall. I'd say that in some studies, more than 80% have at least some degree of CAA. Long-term effects have not been studied to date, which is to say that I think these trials go on for a period of maybe 18 months. What happens 2, 3, 5 years afterwards, after this vascular injury takes place, and assuming the patient survives, does that compromise the integrity of the blood vessel wall? Does that lead to microaneurysms? Does that present a future risk for hemorrhage down the road? And then what is the extent of volume loss in such cases in the brain with all this phagocytosis of amyloid going on? And then finally, the risk of TPA in tandem with A-beta therapy, I think, in my opinion, is very problematic. And I can't imagine a scenario where someone who is on these drugs over, let's say, in the subacute term, and then presents with stroke-like symptoms. I think you're really making a life and death decision, and you're bringing into the equation a man-made disease, so to speak, a drug-induced disease. And TPA is really meant for patients presenting in the natural disease scenario. The algorithms are based on patients with natural disease, not patients with natural disease plus these agents. So I think this issue in particular, I think, requires a lot of deliberation and a lot of thought, because from our own anecdotal case, I can't see why this would not be absolutely contraindicated in these individuals. Just my opinion. And so long and short of it is, I think more research is needed to better understand the toxicity of these drugs, in particular the vascular toxicity, which is substantial from the cases that I've seen. And that's all I have. Thanks. And let me stop sharing here.
Very much, Professor Castellani. Next up will be Professor Herrup.
He doesn't have he's on mute.
I think you're on mute, Professor.
How's that? Yes.
Perfect.
Okay. Unmute myself. All right. Can everybody see my screen?
Yes, we can. Thank you.
Yes.
Very good. Okay. So I want to take my 10 minutes to approach the topic of today's webinar from the vantage point of a basic scientist, which is pretty much all I can do because that's what I am. So I think the idea that there's still no good answers to the origins and therapies that can help us attack Alzheimer's remains true to this day. So, okay. So this is the amyloid cascade hypothesis. Everybody, I'm sure, on the webinar knows it. The key to the hypothesis is that it is a beta and its aggregation that leads to the a linear series of events that results in the dementia that we know as Alzheimer's disease. We have tested the amyloid cascade hypothesis, and in every way we test it, it comes up wanting. So there are two sort of cardinal tests that we can do. The first is the hypothesis would predict that if we added amyloid to the brains of healthy people, that they should come down with Alzheimer's disease. And as Dr. Espay beautifully showed in his presentation, that simply is not true. And just simply stated, approximately 1/3 of healthy seniors have plaque burdens in their brain that would be consistent with a diagnosis of Alzheimer's. Now, these individuals are at a slightly increased risk of developing, but I'd underline the word slight, because 5 years later, literally half of these people will still be symptom-free. And in my world, that's incompatible with a model in which A beta is and amyloid is generative of the dementia we know as Alzheimer's. And just to show you what this is like, I mean, this is and this can be repeated by any number of times. If you look in a normal individual, you see low PET signals for both tau and amyloid. If you look at an Alzheimer patient, you see high signals, and this is, of course, consistent with the hypothesis. The problem is that if you look in normal adults with cognition well intact, you can also find high tau and high amyloid in people who are cognitively intact. This should cause us to re-examine our hypothesis and at least modify it, which has not been the case. But we can also test it in a different way. We can take amyloid out of the brain of individuals, and by the hypothesis, that actually should slow or perhaps stop the progression of the disease. And as you are probably all aware, people with amyloid removed mostly do not fare any better than people on placebo. In fact, often they will get worse. So, and we can get rid of amyloid in a number of ways. We can vaccinate it against it, as the topic of today's webinar would remind us. But we can also block the synthesis by blocking the secretases. And I want to show in my next slide a complicated but very enlightening table that Dr. Espay put together, and I've modified, as I'll show you in a minute. The key is that in what you see, this is a list of all the clinical trials of amyloid reducing agents that have been done. The green here shows that in these trials, amyloid was indeed reduced. And the green here shows all the trials in which cognition actually improved. And what should jump out at you just from the colors is that in most trials, cognition either didn't change or it got worse, and that's the red. Now, we're here today to discuss this little thing here, which is aducanumab, and to that we can now add lecanemab and donanemab. These are three recent trials in which a modest but statistically significant slowing of the rate of decline was observed. As Dr. Espay pointed out, that slowing was modest at best, and by many accounts, it would be clinically undetectable in an individual. And if I may be allowed a little sarcasm, I would say that if you set the bar low enough, you can achieve just about anything. And if I can go to my next slide. So the point I want to make for the rest of this discussion is not to go over these arguments, but to try and look forward and say, well, where are we? And I would argue that you can't dismiss the antibody trials. There were two clean trials. Aducanumab was not quite clean. but they cannot be dismissed. They met their clinical endpoints. They slowed a decline slightly, but significantly. I think, as Dr. Espay pointed out, and as I'm going to emphasize in a moment, we don't actually know why they did that. But they were all separate trials of the same amyloid-based disease models. Our problem, though, is threefold. They're expensive, they're dangerous, and I would argue that they don't work. So hugely expensive is a tremendous problem for our healthcare system. The annual cost could easily be in the range of $50,000 a year for someone who needed the scans to both document their ability to participate in therapy, and then for the drug itself. The risk profiles, as Dr. Castellani just beautifully showed you, are serious and concerning, and the imaging abnormalities are real, and they affected anywhere from a quarter to a third of all the participants in the study, and there were deaths, and that could be reasonably attributed to the drug itself. And as Dr. Espay has already shown you, the effect size is small at best. And I would add to it, which has not come up in discussion, that there were subgroup differences. Now, the trials were not powered to make these statements with any force, but men did much better than women in these trials. In fact, they did threefold better. North Americans did much better than Europeans for reasons that are totally unclear. And ApoE4 carriers actually benefited very little from the therapy. And what I want to argue for the rest of the talk is that these differences remind us and challenge us, because we actually don't know how these treatments work. And if we're going to move forward, we have to understand that in great depth. So we can't move forward. We know that at least the signals on PET were reduced, and this was enough for the FDA to approve these drugs. But it is not nearly enough for me as a basic scientist, and as I have argued. So why was cognitive decline slowed? We actually don't know, and I've argued on many occasions, and I think it's worth thinking about here, is that if A-beta truly is a toxic element in any stage of aggregation, well, just how does it kill a cell? And the answer to that is no one really knows, or at least let me say, there's no uniform agreement on the root of toxicity for an A-beta species. And there are other problems that we need to deal with, and this is the one that I've been working on most recently. So let me go to the next slide, if I might. So this is a graph of our cognitive, it's a theoretical graph, but it's a graph of our cognitive capacity with age. And as you can see, our performance peaks in midlife and then declines afterwards. And I've actually been looking into this rate of decline, and it's steeper than those of us above this peak would like to admit, but it is serious. So we can look at this at any age, and I've picked 80 years of age as just an example. At any time after this decline starts, our performance is off of our peak. And I call this difference delta H. So it's the difference that is a part of normal healthy aging. Fine. Dementia, though, sets in and increases the rate of loss of our cognitive capacity. And so once it starts, our rate of decline accelerates, and that's this orange line that I've shown you here. But there's an interesting sidelight to this, which is, I think, needs to a lot more consideration than it's getting, and that is that this difference between the normal healthy aging and the decline in dementia, we can call that delta D for delta dementia. And what if you look at these graphs, what it tells you is that at any point once dementia starts, the cognitive status the loss of cognitive status is actually a function of two elements. It's the loss in healthy aging plus the loss in dementia. And we don't know which of these was affected by the monoclonals. Was it delta H or delta D? Now, let's be clear. To a person with dementia, it doesn't matter. They'll get better, and that's fine. But to us as researchers, it matters a whole lot, because we need to know, are we treating Alzheimer's or are we just fixing aging? And we didn't do the one control that needed to be done. It's an awkward control. It's expensive. And I think it's a little bit ethically challenged given the safety profile that Dr. Castellani told you about. But if we were to give these monoclonals to healthy elderly people and saw that they too improved, then we can assume that the monoclonals are just working on healthy aging. If, on the other hand, oops, sorry about that, they stay how do I go backwards? If they stay the same, then we can assume that we're working on delta D and actually working on dementia. But we do not know the answer to this question. And that means we're a long way from using any of these terms which have been applied to the monoclonal therapies. They are not a breakthrough. They are not a game changer. And they certainly are not a disease-modifying therapy. So with that, I'll just acknowledge where I'm from and look forward to the discussion.
Thank you very much, Dr. Herrup. It was a very good presentation, and we'll, I'm getting a signal to look at a certain camera again. Anyway, so I will finish up as moderator with my own presentation. All right, so what I would like to do is to talk a little bit about the presentation that we had yesterday at the clinical trials for Alzheimer's disease here in Boston. So this is a version of the presentation. So what I did was, well, let me just backtrack slightly. In looking at the presentation, sitting in on presentations at the CTAD 2023, I think there's room for optimism about not just preventing, but certainly addressing the symptoms of Alzheimer's and dementia. So the future looks hopeful. But my presentation is about having a look at the past. What has happened in the past? Because you can recall, everyone has heard this, but people who don't know or understand history are doomed to repeat it. And I certainly find a pattern of repetition in the last 20 years in terms of the monoclonal antibody therapy. So with that, and kind of relying on my expertise and bias in terms of systematic reviews and meta-analysis, let me just give you a little bit of the background, because this is the parameters of today's discussion, which is that the FDA recently approved aducanumab and lecanemab for treating Alzheimer's disease. Well, certainly multiple clinical trials have been performed over the years using this class of drugs, and it has been mentioned in previous presentations. So our objective is to review the data from previous clinical trials to determine the performance of this class of drugs. My focus is on clinical efficacy, and I'll show you how we did that. So first, we systematically searched all the published evidence for treatments with anti-AB monoclonal antibody drugs. And I won't read you this list, but we found 9 that had gone through at least a phase 2 trial. Many had multiple phase 3 trials. So this was the basis of our data and our data extraction. Some of the drugs that we found did not make it to a phase 2 trial. They stopped at phase 1 because of a lack of efficacy. Others had multiple phase 3 trials that I just mentioned. So in the interest of extracting as much data as possible in terms of the changes in function, we focused on two most frequently reported outcome scales, the CDR-SB and the ADAS-Cog. Both of these scales are the same in the sense that a higher score provides a worse function, worse cognitive function. So in terms of methods, we had what I would call two units of analysis. So unit of analysis, the first one is that nearly all trials reported the difference at the end of the trial, whether it's 78 weeks or 75 weeks, et cetera, the difference between the drug and placebo in terms of the scale, CDR-SB and ADAS-Cog. So we took the convention that we would take the treatment score minus the placebo score. So that usually results in a negative value. In other words, lower score minus higher score equals a minus value. So let me give you a couple of examples from the published literature to show you what I mean by the difference between drug and placebo, and hence our unit of analysis one. These are a couple of recent publications, one by Van Dyke and one by Sims. And you can see that the two endpoints, I think, does my cursor work? Yeah, okay, great. So this is the difference that we examine, right? So right there, the difference between these two values would become the unit of analysis, the first unit of analysis. So you can see that down here, this particular difference is 0.7, and this particular difference is 0.45. So the other unit of analysis is we wanted to take another perspective in terms of what was happening with the two plots, the data. So we decided to look at how fast the two groups were declining, the placebo and the drug group. So I figure, okay, well, that's the slope, a slope of a line. We all learned that, I don't know, in algebra in high school or whatever. So slope is pretty easy to calculate if you have the change in y over change in x. In this case, it's the change in the scale over the change in the number of weeks that the trial went on. So this is to show you again the same slides, but I wanted to know whether the slopes of these lines differ. In other words, do the drug and the placebo decrease or decline at the same rate or not? Right. So to do that, it would be, in terms of a meta-analysis, very simple to just calculate the mean, the standard deviation of the differences, the 95% confidence interval, and so on. But I decided to use a methodology called the bootstrap. This was a methodology that was that came up is attributed to Professor Efron from Stanford University. A number of years ago, he published an article and then followed with a very comprehensive textbook. So, in those days, we didn't call it machine learning or AI. These are the more current terms, especially the AI thing. But it's along the same idea. The idea is that if you, Professor Efron said, all we really know about a data is the current sample on hand. In other words, when we have a sample of patients in an arm of an Alzheimer's trial, we don't draw it randomly from all the folks that might be eligible for the trial, right? What we do is we rely on volunteers, we screen them, et cetera, et cetera. So we don't know much about that set of patients except what we have on hand, what we can measure. So the resampling process is structured in a way that you take the original sample, whatever you have on hand, and draw a random sample from that sample with replacement. So any item within the original sample can be represented more than once. And from that, we build a sampling distribution where we can calculate the means, median, et cetera, the standard statistics. So here's something I found that might make it a little bit more understandable in terms of the resampling process. So this would be the original sample. So especially for an old guy like me, the color balls work much better. You know, I'm experiencing that decline that Professor Herrup showed, the delta aging, right? So if you, the first sample you would draw, you can see that, you know, without looking at numbers, of course, the green balls are represented twice. Because, for example, if the green is randomly sampled from the original sample, once it is returned. So that is now eligible, you know, 1 in 5 chance of getting selected again, right? So you can see what's happening. So here's a second sample, right? So again, you can see that, in fact, this mirrors the original sample. Well, how about a third sample? Well, you can see that the blue balls got selected twice and the purple ball got selected twice. Again, because this is sampling with replacement. It means that after you draw a purple ball, it gets returned into the bin, so to speak, and it is 1 in 5 chance of getting selected again. So that's the idea behind the bootstrap. So each time you draw a sample here, let's suppose you're interested in the average value or the mean of each resample, you can certainly calculate that because you just add up the numbers from the balls and divide it by 5, and then you get the mean, right? So here you'll have 3 means. So that's the start of a distribution, a frequency distribution, how often a particular mean comes up. Well, what we did was we took the data, the difference data from the clinical trials that we examined, and we did this 10,000 times. Okay, so you can imagine that without computing power, I'd still be doing it. I would have started several years ago, and I'll still be drawing samples. So we calculate the mean and the, you know, et cetera, from 10,000 samples or resamples. We create a sampling distribution from the differences that were published for the CDR-SB and ADAS-Cog. And then we calculate the slopes for the drugs and placebo. So this is just a table I put together of the data for just the CDR-SB, right? But for the ADAS-Cog, it's the same kind of situation. So these are the individual differences from the trials. So you can see there's a range of differences from, you know, a difference of plus 1.3, which means that it actually favors the placebo. So I remember what I said before, the way in which the direction of subtraction is such that a negative means that it favors the drug. And remember, this is on the CDR-SB score, which has a range of 0 to 18. And so there were 16 items. It's like we had 16 balls in our bin, and we selected 16 balls with each, but with replacement. So we did that 10,000 times. Well, I didn't do it. The script that I wrote, the algorithm did it. And it actually took a few seconds, if you can imagine that. So the results. Well, all the clinical trials that were published and that we selected for our analysis were all randomized, placebo-controlled. If you just look at the phase 3 trials, sample sizes for each arm range from 253 to over 1,000 per arm. The median number of participants in each arm was 519. Trial length, 76 weeks to 105 weeks, median 78 weeks. All right, so for the bootstrap mean, in other words, after 10,000 iterations, and each time, each sample, we calculate a mean, and then we developed a sampling distribution. So for the CDR-SB, the average difference, the mean difference between the placebo and the drug arm turns out to be 11. With obviously, if it's negative, then that means that the drug arm scored better or smaller number compared to the placebo. Now, the range was minus 0.7 to 1.3. And for the ADAS-Cog, the average difference was minus 0.52. And here's the range. Keeping in mind that the potential range of scores for the CDR-SB is 18, 0 to 18. And the ADAS-Cog is from 0 to 70, 80, or 90, depending on the number of items. In other words, the ADAS-Cog 11, 12, 13, etc. Right, for the slopes, we did the same kind of thing. You can see that the slope of for the drug condition for the CDR-SB is 0.024. For the placebo, is 0.026. For the ADAS-Cog, the slope was 0.081. For the placebo, 0.078. So you can see that there's a whole very little difference between the trajectory. In other words, the rate of decline in those lines that I showed you before between drug and placebo. So one of the things that was interesting was that for the difference between drug and placebo for the CDR-SB, they both included 0 in terms of the 95% confidence interval. Now, the differences that I've shown you are really quite small across trials for all 9 of these monoclonal antibody drugs. So we can certainly say that these results cannot be considered as either clinically or statistically significant for the treatment of Alzheimer's disease. The slopes are also very similar. In other words, the similarity in slopes between drug and placebo show that the decline in function as measured by these 2 scales are very similar, nearly identical. So the participants in these trials overall appear to worsen over time at very similar rates. So the collective evidence from these clinical trials show that the treatment of Alzheimer's disease, as far as the treatment for Alzheimer's disease, these drugs did not appear to have a measurable clinical effect, and almost all anti-amyloid drugs are associated with serious adverse effects. I think several of the professors have alluded to this before. So our overall conclusion is that these trials, across all these trials, it's really been a history of failures. And I think my last slide is just a quick look at the ARIA issues that are associated with these drugs. Okay. That's my presentation. So what I'd like to do now is to have a discussion initially among all the panelists. In other words, if you would like to elaborate or comment on what I've said or any of the other panelists have said, we'll just go ahead.
Well, I guess I could start just saying I think that the 4 speakers were in pretty serious agreement that we have therapies that are minimally, if at all, effective, and that are quite significantly dangerous, and that, and again, my frustration is not, and one of the questions that came up in the chat was, what are our hypotheses for what does cause Alzheimer's? It's hard for us to move forward, really, in the environment that we're currently in. I'm curious what my colleagues have to say about that as well.
Yeah, I fully agree with you, Karl. By the way, I liked very much that last presentation on the analysis. Very well done indeed. And it's interesting that one of the analyses that I think is, or maybe two that have been around in terms of supporting the value of lecanemab, and I think will be the same with donanemab, is the extension of 6 months that this gives, and it's a measure that in a way relates to the slope analysis. But your slope analysis, the one you just presented, so has indicated that really these curves aren't divergent as we like to believe by squeezing our eyes and looking at the data. And so that's one thing I wanted to ask. And then the second, of course, is this 27% in the case of lecanemab, and I think it's 34, 36% in the donanemab. These numbers of change appear impressive. And they're quite misleading because they are the reflection of the arms of the studies in relative change, not exactly accounting for where people start and where they ended in the trial. So I know you want to add a comment to the effect of how your analysis fits into the narrative that here we have really good gains and that we're gaining 6 months of extra life without symptoms or something like that.
Yes, we actually, during the last webinar in June, we addressed that issue about the 27% gain versus is that accurate? And you're right. These are relative numbers. So what the investigators did, the folks who ran the trial, was that they used a denominator that did not reflect the actual score itself. So they use a much smaller denominator rather than the actual value of the score on the scale. So for example, I think I'm kind of can't remember all the exact numbers, but instead of using 4.3, which is actually the value of the scale itself on a scale of say 0 to 14, they use the difference as the denominator. And so I think that inflated the percentages. I think when we calculated the percentage based on the actual value of the score for those patients at the end point, it came out to be, I believe it was 9% or something as compared to 27%. So yeah, you're absolutely right. That was a great observation. And yes, that's what has happened. The percentages have been exaggerated to make the drug look good. I wouldn't say that's unethical, but I think it's in their interest to make what they've spent hundreds of millions or billions of dollars on to look as good as possible.
Right. I'm very impressed. I learned from Professor Castellani about this idea that the MRI is not as sensitive as we've believed in terms of identifying individuals that may have cerebral amyloid angiopathy. That's another risk that will then be inflated, I would imagine, once this drug is used more widely, if it will be used more widely. That's a very worrisome scenario there. And I imagine that's probably what keeps you up at night, Professor Castellani.
Yeah, well, I'm not a radiologist, but my understanding is that MRIs detect complicated disease. In other words, there has to be hemorrhage, microhemorrhage or siderosis, then the various single computer acquisition sequences will pick up a signal abnormality. But if you look at Alzheimer brains on a regular basis, like I do, you will find individuals with abundant cerebral amyloid angiopathy, which is a target of these drugs, that have no evidence of complicated cerebral amyloid angiopathy, but the target is still there, and so the complications are still possible. So I would suggest that we avoid the pitfall of talking about anecdotal cases and looking at them as outliers. They're actually they're somewhat fortuitous in that both the cases that I showed you were examined within weeks of instituting therapy. So we have actually a very good look at what's going on while the drug is having its effects. And that's, in order to do that, somebody unfortunately has to pass away, and that doesn't happen very often. But I think it's interesting that these passive therapies have been around for, I don't know, about 15 years, I guess. And we have very little knowledge, very little insight into what's going on in the brain in terms of clearance and in terms of the effects that we're seeing. And so the case that I show you, it's clear to me as a pathologist what's going on. And it's also clear that the drug has its intended purpose. It is engaging amyloid beta. It just happens to include the insoluble amyloid beta that's within blood vessel walls, and that has a consequence. And I think my hypothesis is that a lot of what we call ARIA is due to a effect of these agents on blood vessels, on the vasculature, and including a necrotizing vasculitis. And the amount of amyloid will vary from very little to none to a lot in any individual case, and it's really hard to sort those out on imaging. So I just wanted to point that out. The other thing I would mention is that autopsy examination just doesn't drop out of the sky. So if somebody passes away and they're not part of a study, either the family has to have the insight to pursue an autopsy, or it comes through, for example, the medical examiner system. And now, if somebody dies outside the hospital, and a patient with Alzheimer's and a lot of comorbidities presents to a death investigation, I can tell you that most medical examiners, if not all, will not pursue an autopsy in those cases because they have the cause and manner of death, which is what their task is. So getting autopsy information on these cases is not trivial. It's difficult. And our own center, at Northwestern, our social workers do a tremendous job of following up with families and making sure that if they're part of the study, they get autopsies. But if they're not part of a study, it takes an effort on the part of the family and consent of the next of kin to pursue that information. But it is somewhat striking that there's so little autopsy information is available, given that these trials have been going on for 15 years. I would suggest that maybe there should be a more aggressive effort at pursuing autopsy, so we can see how common these complications are. Anyway, I just want to throw that into.
So I have a question, actually, because I think a lot about the placebo arm of these trials. So an infusion of an engineered monoclonal is not totally benign. And I just wonder if you have experience from other fields with other monoclonals, whether there's pathology just from the act of putting in an immunoglobulin. And if not, then we can lay the problem at the foot of the actual target of the antibody itself.
Well, I personally don't have, giving immunotherapy is becoming more and more common, and
right.
They certainly have an effect. They certainly target various, inflammatory cells and so forth. So, and yeah, there can be adverse effects from that. I don't want to tell tales out of school here, but yes, immunotherapies are very common, and there are toxic side effects as well as benefit. But But again, in this case, I think it's important to appreciate that the target of the therapy is in the cortical blood vessels in many individuals, and you know, that by itself is kind of unique to these constructs.
Right. I totally agree.
Other questions for among the panelists? I have one question for Professor Espay. I was curious about one of the slides that you presented, or you showed it in your presentation, that was showed donepezil versus, I think it might have been lecanemab on the ADAS-Cog, and donepezil appears to perform very well compared to lecanemab. Did I see that right?
Yeah, you did. The donepezil has essentially 2 times the effect size of lecanemab. It's quite remarkable because we think of donepezil as one of the most modest of therapies we have, and yet compared with lecanemab, it emerges quite favorable. Admittedly, we're talking about 24-month duration or 24-week duration of study compared to 18 months. But as you saw, the baseline is never broached in the negative. It's the curves is in fact showing an actual benefit. And part of the reason I like to show the 2 curves is not just to emphasize that there is a difference between them in terms of the effect size at the end, but the fact that when you align them properly from baseline, no one in lecanemab improves. And I think that's the most important message to counsel patients for those clinicians that will wish to provide this therapy to their patients. I cannot do it based on all I know, but for the people that would, they would have to counsel them that they will not get better, that there is no improvement to be expected, that they have to believe that the reduction or that the decline that they will have somehow will be less steep than if they were not on biweekly infusions. That's something they have to believe, because the effect is below the minimal clinical important difference, meaning that the declined differential from placebo is half of what is needed for patients to perceive that change. So when we talk about benefit, we should really be speaking in terms of the statistical differences, but not of any clinical meaningful change, and certainly not improvement. So this is so critical for patients to know. There is no improvement in anyone. There is just a slower rate of the decline, but donepezil actually improved people, and that is quite remarkable, of course, at a fraction of the cost and far safer than lecanemab.
So, you know, one of the phrases that I think I coined, maybe not, but I said, if you look at the lecanemab curve, the drug arm got less worse than the placebo arm, and that's what you're saying. So just a quick follow-up question to that. So then why isn't donepezil in wider use, or is it still in wide use?
I think it's still very much in wide use, but we aren't particularly as ebullient about it as we may have been back when we first had it. It's so interesting. This idea of the curves divergent we think is a new artifact of the newer antibodies, because they are meant to be disease modifying, which of course, as you've pointed out, they are not. But we've always looked at the curves as if they reflect a slope that is to be expressed far better beyond the time window of a trial. We think the window of a trial is too small, but if we believe, the word belief is not a good one in science, but we use it quite often, that moving forward beyond a year or 2 or 5, then the differences will be much more important. So it's not so much what happens at the end of the study. We argue is what will be expected to occur later. And with donepezil, we have plenty of experience to know that those curves did not diverge quite in the manner we thought we had seen. So donepezil remains in wide use, but it's very little that we can see truly meaningfully emerging from the use of that medication in patients.
Okay, I'd like to switch a little bit in the time remaining to some previous questions that were submitted from the attendees. So I've kind of distilled down because trying to put them together in little blocks. One of the issues that was brought up by a lot of the registered folks is and I think it's probably been answered by almost everybody, but what's the cost-benefit ratio of these antibody drugs? And anyone can answer there in terms of the panelists.
Alberto, I think that's for you.
Sure. This is a drug that we cannot calculate the number needed to treat. The number needed to treat is a number of people that would need to receive this medication for one to benefit. That requires a metric called the responder rate. The responder rate requires a patient to admit improvement, and because there was no improvement above baseline, we don't have a number for the number needed to treat, largely because the number doesn't exist. No one improved. But the number needed to harm, which is the number of individuals you would give the treatment for one to worsen, is 3. So you get a clearly low number needed to harm, and unknown and potentially infinite number needed to treat. That data alone tells us that the risk-benefit ratio is unfavorable. And that alone tells us that this drug is not cost-effective at any price. Furthermore, what hasn't been discussed and what's very important for patients to know, and clinicians, since we are going to be the ones explaining what this drug is about, is that there is an acceleration of brain atrophy with lecanemab and with actually most monoclonal antibodies. That amounts to about 1 extra teaspoon less brain for lecanemab and 1.5 teaspoon less brain for donanemab. That's a lot less brain. And in any alternative universe, to present the therapy that we want a patient to take for us because we think is important for them, how do we ask them to remember that the implications of a smaller brain aren't really known, and therefore we should not worry about it? In what alternative universe a drug that shrinks the brain somehow is okay to take because we really don't know what that means? Altogether, this drug is really neither effective nor safe. And a question was made by someone, how was it approved? And I argue that it was approved because societally, we believe strongly in the idea that amyloid is Alzheimer's. And it's a beautiful, compelling, logical idea, but it's false. And when we adhere to false ideas, we are going to be destined to live by something that fulfills what we think is right, what we believe, what we hope, even though the evidence is quite against those beliefs. We're the only field of medicine, we neurologists, and I can speak for my kin, that do trials not to test hypotheses. We do trials to learn. And we've consciously said so because we already have endorsed the idea of amyloid being toxic. We shouldn't really be talking about the amyloid hypothesis. We should be talking about the amyloid law, because it's actually something that has become unfalsifiable. If at any meeting a question emerges, could you please let me know what study should be done in order to properly test the hypothesis? And if the study is negative, that data will falsify the hypothesis. The answer is usually befuddlement. I don't know, it's a weird question. And that's because we really don't come to a point ever where we could move away from the idea that amyloid is toxic. So lecanemab and donanemab, we were destined to have because we believe too strongly in it. And it's unfortunate. Science is not about belief, but it is dominating the research in Alzheimer's. And that's why How Not to Study a Disease is the title of Karl Herrup's book on the story of Alzheimer's.
Yeah. And I would just add that the cardinal mistake, I think, was the FDA approving aducanumab. Because of the 3 monoclonals, that was by far the weakest study, with the most sort of hand-waving to get to a significant effect. And yet that was the reduction in amyloid, which no one, well, the reduction in PET signal, which no one would argue did occur. There was target engagement. That, for the FDA, was enough to say, okay, that was probably clinically relevant in the face of a lot of evidence suggesting, no, that's clinically irrelevant.
Right. And that decision also was made on the idea that the window, there will be an expectation of efficacy. It wasn't so much about the window of the trial. Think about what would happen later. That word expectation of later benefits was in fact there in the FDA verbiage. Very unfortunate. As you're saying in your graph, the bar was set so low that anyone could reach it.
Yes, I could dunk a basketball. Anyway, here's a sort of a related question from one of the audience members. Why are there currently no data published comparing lecanemab and drugs such as the Donepezil, or are they?
Not to my knowledge. I don't think that, the studies so far were done in individuals that probably were not on the, actually, come to think of it, of course, the study, we're never going to compare the two, but a number of them probably were on the Donepezil, and I don't know if the Donepezil was exclusionary. If it was,
no, I actually looked into that because I had the same question, and it was not exclusionary.
So there might be then data there to try to determine if any benefit could have in fact be the result of the Donepezil that individuals were on, as opposed to any of the benefits that we think are related to amyloid reduction.
Yeah, that's why when I saw your slide there, Professor, between Donepezil and lecanemab, I was surprised that there wasn't a trial that had the 2 different arms. One is lecanemab and one is Donepezil, and a placebo of some kind, and track the changes.
Right.
So let's see. There was several questions about alternative treatments. In other words, in the absence of a drug treatment, are there anything that an individual can do to mitigate the symptoms of dementia and Alzheimer's?
I would argue that the non-pharmacologic strategies remain the most robust of all the interventions as it relates to changes in overall cognitive and functional capacity. Exercise has an effect size and shown across many studies that far surpass that of any pharmacotherapy we have available. So there is very little use of it. It's been argued by many that investment in an infrastructure to provide the kind of care that patients need, from basic needs, from better nutritional support, and rehabilitation strategies that use exercise and a variety of different physical therapy modalities, has a lot more to offer to patients at a lower investment than any of these monoclonal antibodies could ever do. I think in general, we like something that's given to us, all of us, me included. We love to have our benefits given in a pill or something simple for us to take. But honestly, exercise in this particular example, I think there's nothing that replaces the value of what must be acquired through sweat and shortness of breath. So yeah, that will be probably my answer. It's remarkable. It's an indictment on our field that we don't have quite anything meaningful to offer, and I think it should force us to rethink our entire paradigm. This is quite the message that I hope that this webinar conveys, that we must change. The idea of proving ourselves right, or trying to continue to proving that our ideas were right, will continue to harm patients and limit their possibilities for treatments.
Okay, well, unfortunately, we're going to have to wrap up. We only have a few minutes left. So what I'd like to do is ask the three professors to provide a final statement, if you would call that, just a minute. So let's see, why don't we just go with Dr. Espay?
Sure. Well, thank you very much again for inviting me. I want to conclude by saying that amyloid plaques is not the beginning of anything, it's the end of normal protein. A beta 42 was in our genome before we came to Earth. It's present across all species on Earth. Do we think that evolutionary forces preserved the amyloid beta proteins because at some point we would have our own method of natural selection? Or do we think that, in fact, evolution preserved A beta 42 because it was very important and that it was a very first step in the reaction against a variety of biological, toxic, and infectious stressors? We're missing that in piece of the amyloid plaque. We've been blinded by the idea that plaques is abnormal and that must be the cause of the problem. It is the consequence of the problem. It is the consequence of losing the normal protein that has been preserved, since evolutionary forces have anything to do with where we are on Earth.
Great,
Thank you.
Professor Castellani?
Yeah, well, I guess I would just end by saying that I think these agents are remarkable. The idea that you can put in an IV and a substance that crosses a blood-brain barrier, attacks a specific antigen and brings it out somehow is, I think, a tribute to science in a sense. But from my perspective, there are a lot of discussions about the amyloid cascade and whether the disease process, whether amyloid travels with the disease process or drives it. That's a sort of a separate discussion. But I do not get the sense that the degree, again, of vascular toxicity is adequately accounted for. And I think that what we saw in these individual cases, I think gives us insight into what ARIA is, and that these are actually cytotoxic. It's a form of cytotoxic chemotherapy, and so I think the vascular toxicity again needs to be taken very seriously and addressed. And I think we need to find better ways of sorting out those individuals who have abundant cerebral amyloid and those individuals who don't. I mean, we get to a point, but there will always be idiosyncratic reactions as far as I can tell now. But that's all I have.
Great, thank you. And Professor Herrup?
Well, I'm sorry to do this, but let me end on a note of frustration, because as a basic scientist, the worst question that I get, and I get it all the time, well, okay, if it isn't amyloid, what is it? And I always have to throw up my hands and say, I don't know. And the reason I have to do that, I think, is in large part because just the logical fallacies of the field have driven out a lot of people from our field who don't want to work in this climate anymore. And the people who review our manuscripts and review our grants have bought into the alternative world that Dr. Espay described. And I feel that we may actually need to go back and re-examine our definition of what is Alzheimer's. What exactly is it? But that's a webinar for another day. What I'd like to say most is that I just found this 90 minutes to be really stimulating, and I hope that the participants got as much out of it as I did. It's been a great pleasure. So thanks for the invitation.
Thank you, Dr. Herrup. With that, I'll just say a couple words. And then first, I want to thank all the three panelists for your time and expertise. Very much appreciated. I certainly learned a lot. And I would like to thank the audience, all 450 or whatever the number is at this point, for your attention and for your interest. And finally, you know, I'm by training a biostatistician, a clinical trial specialist and all that. We have a saying, says, in God we trust, all others bring data. So to me, data is king. So take a really close look at the data that are presented by, you know, all these investigators in terms of doing their monoclonal antibody research. With that, thank you very much, and good luck to all of us.
Thanks, been a pleasure.
Thank you.